Well, thank you for that introduction. You will note that nowhere in my bio says that I'm a toxicologist, and then I defer to Dr. Palatnik and his tremendous expertise. But toxicology is one of those topics that is really unique to emergency medicine, and perhaps one of the few topics unique to us, and not only common but also potentially very dangerous. So I have no disclosures. Um, our agenda is ambitious today, so we're going to discuss the approach to the intoxicated patient and review some of the most common toxidromes. We'll discuss how to identify and manage the most serious pediatric ingestions, and then review some general management of common tox presentations. And again, I'll do most of the presenting, and again, so grateful to Dr. Palatnik to answer the tough questions. And grateful for him not only today for answering those questions, but also in the morning when we have to call our toxicology friends on call. So what is unique about toxicology to pediatrics? Similar to other areas of medicine, we must give special consideration for their lower weight. Need to consider the toxin in terms of milligrams per kilograms, increased toxicity for that smaller weight. And I acknowledge that we have a varied audience here. So there may be some folks more familiar with pediatrics and less with toxicology, and some more familiar with toxicology and less with pediatrics. So it's all good, and I'll move quickly. You'll have the slides afterwards. So don't worry if I skip over some things or don't dig deeper into some things, but you'll have the slides. And then I've also chosen to put more details on the slide. So you'll have that for reference later. Okay. So in terms of principles of toxicology, I'd like to think of it as the ABCs, right? We know the ABCs of what they stand for, but P is actually fairly low on that, right? A, B, C, D, E, F, G, of course, airway, breathing, circulation, disability, exposure, family and fast exam, glucose in pediatrics, and P for the poison. So it comes lower on the list. However, we know we treat the patient, not the poison, yet knowing what the poison is can help in the treatment and ultimate management. B for toxicology stands for keeping a broad differential diagnosis and including the possibility of a toxin, especially when you have a group of symptoms or signs that don't make a lot of sense. Consider co-ingestions, consider communication or route of exposure. Could there be exposure through ingestion, injection, skin or eye contamination, inhalation? Comorbid conditions can also play a role. Think about decontamination, avoiding secondary and tertiary exposures to those caring for the patient. And then some empiric therapy. Dextrose and naloxone are the two we use most commonly in pediatrics. And of course, one can also phone a toxicology friend. We all know how to take a history, so I won't dwell on that. But an important clinical pearl in the history is to assume the maximum dose. If a bottle contains 100 tablets and 60 are left, assume the patient took 40, even if the bottle had already been opened and used prior. So I won't try to read this Latin phrase, but the translation is the dose makes the poison. And even many centuries ago, a philosopher opined that all substances are poisons. There is none which is not a poison, and the right dose differentiates a poison and a remedy. And perhaps the best example of this is water. We don't think of that as a poison, and it's life-giving in appropriate amounts, but can be life-threatening if excessive. So we have 5 polls today. Let's start with the first one. A 3-year-old girl presents with altered level of consciousness and tachypnea and smells like peppermint. What did she ingest? So your choices are salicylate, cyanide, organophosphate, camphor. So you should see a poll in front of you. And what do you think she ingested?
And I'm receiving some answers, so it's working.
That's always good. Okay, how many answers do we have?
We have 34.
Okay.
Yeah, I think I can end now.
Great. Okay. So it's a nice mix, anywhere between kind of the low 20s to the low 30s. Okay. And the one that is correct is actually the one that the 20%. And the answer is salicylate. And oil, specifically oil of wintergreen. We often use odors to identify potential poisons, and we'll talk more about the different odors and what they might mean, and salicylate in general, how that can cause tachypnea. Okay, so a quick examination, obviously, measuring temperature, heart rate, respiratory rate, blood pressure, we know all that. But again, clues to what might have been ingested. So temperature is high, especially skin temperature. Could be a sign of anticholinergics or neuroleptics or serotonin syndrome. A low temperature can be seen with opiate overdose. Heart rate, again, high heart rate, anticholinergics and pathomimetics. A low can be with opioids or alcohol. Arrest rate is usually high with aspirin. It can be low with sedatives. Blood pressure, again, high with cholinergics. It can be low with beta blocker or calcium channel blocker overdoses. Eyes, either pupils dilated or constricted. So mydriasis can be seen with anticholinergics. Meiosis can be seen with opiates, as we often know with pinpoint pupils, but also cholinergics. Skin color, red, blue, flushed, jaundice, hot or cool, dry or diaphoretic. An odor, right? An acetone odor can be seen sometimes in alcohols or salicylate poisoning. Wintergreen or peppermint can be seen in salicylate poisoning with oil of wintergreen. A garlic odor can be seen with organophosphates. Bitter almond, cyanide, and then camphor is known for naphthalene or mothballs. We don't see those as much anymore as we used to maybe a few decades ago. And then looking for neurologic signs, delirium, ataxia, nystagmus, paralysis. This is a great slide, which I'm not going to review, but some nice mnemonics of different vital sign aberrancies that can give you a clue to what might be going on. Investigations, we would do the usual, right? CBC, electrolytes, calcium mag phos, liver tests, and so forth. Plus, we may look for some additional clues, right? A PT-INR or a CK myoglobin for evidence of rhabdomyolysis. Lactate can be elevated in a number of poisonings. An ABG or CBG can show you whether there's a metabolic acidosis, can show you methemoglobin or other or carboxyhemoglobin for poisoning. And we will go over mud piles, but you'll remember that your anion gap metabolic acidosis mnemonic for various regions. And on that, of course, includes several toxins, including methanol for M. M is for methanol, and S is for salicylates. Serum osmolality to calculate the osmol gap, getting levels. So traditionally we get levels for acetaminophen, aspirin, and ETOH. And then if indicated by history or clinical presentation, iron, alcohols. Consider a urinalysis, consider an abdominal x-ray, looking if there's any iron pills in the stomach, again, if there's a history of iron ingestion. And then the ECG can be helpful, again, for some clues. Okay. So we'll move on and do a quick review of the various toxidromes, and we'll hopefully dwell just a little bit on each one, but a good review for most. Okay, before we talk about cholinergic and anticholinergic, so let's talk really briefly about cholinergic receptors. There are actually three sets of receptors for acetylcholine. One set is called the nicotinic receptors, and they are found in tobacco, so that's where the name came from, but we've translated that to the human body, of course. These are found in the adrenal gland, autonomic ganglia, and skeletal muscle. The muscarinic receptors are found in cardiac and smooth muscle, the glandular cells, and some nerve terminals. There are different mechanisms of activation, and both receptors play a role in the autonomic nervous system. And again, as a reminder, we think of that as the sympathetic nervous system as our fight or flight. The parasympathetic is more of a rest and digest. And it's more complicated than that, of course, but it's a good way to think about those two toxidromes. It's also important to know that different toxins and different antidotes can have effects at either one or both receptors. Just a very quick diagram to further explain those receptors. Acetylcholine, of course, is part of the sympathetic and as a parasympathetic nervous system, but they work in different ways. So within the sympathetic nervous system, acetylcholine activates nicotinic receptors and then triggers the release of epi and norepi, which then act on adrenergic receptors. In the parasympathetic autonomic system, ACH activates the muscarinic receptors, which then create more acetylcholine. And it also has direct effects on those muscarinic and nicotinic receptors. So too much receptor inactivation, and a anticholinergic, the sympathetic nervous system goes crazy, what they call tacky and wacky, mydriasis, bronchodilation, tachycardia, sweating. Too much cholinergic activation overactivates the parasympathetic nervous system. And then you have meiosis, salivation, lacrimation, bronchoconstriction, and bradycardia, among others. So time for our next poll. So you have a 16-year-old boy working on a farm, and he presents after inhaling an insecticide. What is the most concerning morbidity in organophosphate poisoning? Right, and the questions are on this, or the answer choices are on the slide and on the poll in front of you. So it's CNS depression, seizure, respiratory failure, bronchospasm. The most concerning morbidity in organophosphate poisoning. Okay. Okay, so great answer. So CNS depression, seizure, respiratory failure, bronchospasm. The overwhelming number of you picked respiratory failure, which is correct. However, bronchospasm is also correct. Now, seizure and CNS depression are also side effects of organophosphate poisoning, but not the most serious one in terms of life-threatening. So we think of bronchospasm and bronchorrhea from the muscarinic receptors and respiratory failure from the nicotinic or central receptors. So absolutely right. So cholinergic, most cholinergic poisons decrease the acetylcholinesterase, which of course results in increased acetylcholine, and we do see effects at all three receptors. So examples of cholinergic poisons include organophosphates, and medications that decrease intraocular pressure, so drugs for glaucoma, some Alzheimer drugs, so physostigmine, neostigmine, etc. Chemical weapons such as nerve gas, and then some mushrooms. The onset of and duration of symptoms, of course, varies, and the younger patients are more likely to have seizures and CNS toxicity from central effects. So it's helpful to think of groups of symptoms by receptor type. We'll start with muscarinic, and you may have your own mnemonic for this, but we talk about dumbbells, diarrhea, diaphoresis, urination, meiosis, bronchospasm, bronchorrhea, and bradycardia, emesis, lacrimation, lethargy, and salivation. We talk about bronchospasm and bronchorrhea as the killer bees, and there's a high risk of aspiration pneumonia here. You may have learned about cholinergic symptoms with the word sludge, but it was missing the bees, and the bees are really what are the most dangerous. In terms of the nicotinic receptors, a good mnemonic is days of the week. So mydriasis, tachycardia, weakness, and again, this includes the respiratory muscles and paralysis, which can lead to respiratory failure, tremors, hypertension, fasciculations, seizures, and somnolence. But you note that muscarinic receptors actually give you meiosis, while the nicotinic receptors give you mydriasis, so they can vary based on the toxin. And then, of course, central effects. We talked about seizures and other forms of depression, CNS depression. A common theme for any toxin will be supportive care. In this case, special attention to airway management, secretions, also managing hemodynamics. Pharmacologic, you can use atropine, but it only affects the muscarinic receptors. And so generally you give small doses until you start seeing some anticholinergic symptoms. And I would do this certainly under the guidance of a toxicologist. Pralidoxime is another option. It reactivates cholinesterase, separates toxin from the receptor, and can be helpful in organophosphate poisoning, and does also reverse nicotinic effects, but does not cross the blood-brain barrier. And so that's another one that you give until you start seeing effects. Benzos will be a cure or a treatment dose or option for almost every toxin, but you'll see benzos a lot to try to calm things down. Epinephrine if there's hemodynamic instability. And then we're careful with the choice of paralyzing agents. So in in cholinergic poison, we usually avoid succinylcholine because of the depolarizing effect. Okay, moving on to anticholinergic. So there's some examples here, the antis, right? Antipsychotic, antispasmodic, both used for diarrhea and for bladder spasms. Antidepressants, tricyclic antidepressants, for example, I have some anticholinergic effects. Antisialagogues, dextromethorphan, carbamazepine, and then many medications involve other receptors as well. So anticholinergic poisons in general work as a competitive antagonist at receptor sites. And you can also have those three receptors as we talked about. The central receptor from the restless, agitated, hallucination, psychosis, seizures, coma, more the CNS effect. The muscarinic receptors are the ones that we've learned as hot as a hare, blind as a bat, red as a beet. Hot as a hare fever, blind as a bat mydriasis, which is unreactive to light, red as a beet, vasodilatation, dry as a bone, anhidrosis, mad as a hatter, full as a flask, urinary retention. And the nicotinic receptors are not affected by anticholinergic meds. And then you can also see hemodynamic changes, including hypertension, tachycardia, and EKG changes. So for those of you who like pictures and are more visual learners, I threw this in as well. And if we have time, does anyone want to throw in the chat? Why do we say mad as a hatter? And of course, those of you who have read Alice in Wonderland knows where the Mad Hatter comes from. Where does that phrase come from, mad as a hatter or the Mad Hatter? Does anyone know? This is not a poll, it's just trivia more than anything. So Mad Hatter came because hat makers used to use mercuric nitrate to remove fur from the beaver or the rabbit pelt that they were using for hats. And over time, they would get mercury poisoning. Yep. There you go, mercury. Mercury poisoning. And so long-term exposure caused irritability and mania and other problems. And then today's haberdashers use hydrogen peroxide, which is a bit slower, but it's safer. So yeah, so a lot of hatters apparently after a while went mad from mercury poisoning. So in case you're ever on Jeopardy. There you go. So the main management of an anticholinergic toxidrome is, as usual, supportive care. It is possible to use physostigmine, which inhibits acetylcholinesterase. You get more acetylcholine. You can use it peripheral and central signs. Have atropine ready if there's dangerous cholinergic symptoms. You don't want to go too far the other way. But it can be used under guidance of toxicology. There is some controversy around physostigmine, but most toxicologists would favor its use. And again, administering that in consultation with toxicology. Okay. The final slide kind of in this category, one is that anticholinergic symptoms can overlap with both serotonin syndrome and neuroleptic malignant syndrome. And of the three, at least in pediatric emergency medicine, we see serotonin syndrome probably the most. But remember that serotonin syndrome is more sympathomimetic. There's a lot of overlap. They can all have hypertension and tachycardia. Anticholinergic patients usually have dry skin, where serotonin and NMS patients are more diaphoretic. So how can you tell the difference? Hopefully there's some history to go on, but if not, here's another esoteric fact which you might find interesting. I mentioned that both sympathomimetic or serotonin syndrome and anticholinergic syndrome causes mydriasis, but it's different mechanisms. So the mydriasis in serotonin or sympathomimetic syndrome is overstimulation from the pupillary dilator muscles, and so you can actually overcome that by shining a light into their eye. in anticholinergic symptoms, anticholinergic syndromes, the mechanism is actually a blockade of the pupillary sphincter receptors, and so you can't overcome it. So in one case it's reactive, in another case it's non-reactive. So hopefully you have more to go on than that, but that's just an interesting clue. Fortunately, the treatment for both is benzodiazepines, which, as mentioned before, is a trend here with treatment for many toxidromes, except for a benzo overdose, of course. And we've talked about that, the use of treatment for anticholinergic toxicity. And then for neuroleptic malignant syndrome, one could also consider bromocriptine and dantrolene. So it's a good segue into the sympathomimetic toxidrome. So basically, this is unopposed adrenergic toxicity. So all systems are up. So elevated vital signs, all the vital signs, agitation, seizures, psychosis sometimes, or psychotic symptoms, rhabdomyolysis. And what's interesting in this toxidrome, or a clue that you can find on lab work, is hyponatremia. And there are at least two reasons for this. One is water intoxication, because patients drink so much to try to alleviate some of their symptoms. And then in toxicity from MDMA, patients can actually develop SIADH, which of course further potentiates the problem and has caused deaths. And of course, we have many examples of sympathomimetic drugs, such as methamphetamine, MDMA, ecstasy, ketamine, marijuana, cocaine. And then besides drugs per se, you can, if you think about malignant hyperthermia, also presents very similar to this sympathomimetic toxidrome, although not is not a toxic drug related, but toxic certainly to that patient. Certainly herbal preparations such as ma huang, and we talked about serotonin and NMS. Treatment is supportive care, IV fluids and cooling. And pharmacologic interventions could include sedation with benzodiazepines, and some patients also benefit from propofol if needed. Some short-acting hypertensives. Benzos, of course, can help with the hypertension, or short-acting hypertensives such as nicardipine, and antipsychotics, anti-seizure meds if needed, and then alkalinization and diuresis for some. Just one quick slide on opioid and opiate toxicity. And as a reminder, they present similarly, but those are two different classes of medications. Opioids are synthetic or semi-synthetic drugs like fentanyl. Opiates are derived from the poppy, so morphine and heroin are opiates. But ultimately, the toxidrome is very similar. The presentation, we talk about the classic triad, right? So CNS depression, respiratory depression, and meiosis. You can also see bradycardia and hypotension, hypothermia, and hyporeflexia as well. Antidotes were, I think everyone on this call is familiar with naloxone, which can be given in many ways, IV, intramuscular, intranasal. We usually start with a lower dose and then increase and repeat as needed. And we do need to re-administer frequently. Remember that naloxone has a shorter half-life than most toxins, and you may need to, or likely will need to, repeat that. What we want to avoid precipitating withdrawal, and that's one reason for starting at a lower dose and working our way up. One slide on sedative toxicity, which mainly presents with sedative effects, unsurprisingly. And examples would include benzo overdoses, muscle relaxants, sleep aids, the Z drugs, barbiturates we don't see as often, but alcohol as well. So the main difference in presentation between a sedative and an opiate toxicity is on the pupillary size. So opiates, we talked about the pinpoint pupils, and sedatives have no effect on pupil size. Management is supportive care. So we've learned about flumazenil before, that is somewhat controversial in terms of a reversal agent for benzodiazepines. It can be dangerous if it's not a pure benzo overdose, and many of our patients who come in with an overdose are not a single agent. So most toxicology experts do not recommend the use of flumazenil, as it can precipitate seizures. And overall, sedative overdoses are fairly benign poisoning if supportive care, of course, is given. So balancing the risks and benefits. Okay, so we'll go on to poll number 3. So we have a 15-year-old girl presents after intentionally ingesting a bottle of her father's amitriptyline medication. What should you remember when using bicarbonate in a toxic ingestion? To give sodium bicarbonate until the QRS narrows, Replace potassium if needed prior to alkalinization. Your goal serum pH or urine pH is 7.50 to 7.55. It's effective for weak acid toxins. None of the above or all of the above. Give you a chance to vote. Okay, so all of the answers are correct. So the answer is all of the above, but if you answered one of the individual answers, that is also correct. So, so in terms of giving the sodium bicarbonate, there is an upper limit of giving sodium bicarbonate, and you would usually stop if the pH is greater than 7.5, kind of a hard stop, even if the QRS is still not completely narrow. So yeah, this just says all of the above. Awesome. So our final toxidrome is from agents which cause sodium channel blockade. And rather than talking about like a tricyclic antidepressant overdose, there are multiple drugs that can cause blockade of the sodium channels. And we'll talk about the management as a group, right? So this is mostly drugs affecting the fast sodium channel. So these are often antiarrhythmics, which are good membrane suppressants in recommended doses, but not so good in toxic doses. So there's many examples of sodium channel blocker overdoses. Perhaps in the past, most common was the tricyclic antidepressants, which again have other symptoms than just sodium channel blocker. We're seeing that less nowadays because we're seeing more serotonin syndrome because of the switch to using fewer TCAs and more SSRIs or SNRIs. Some SSRIs, SNRIs can cause sodium channel blockade. However, some beta blockers, antihistamines, antiarrhythmics we talked about, such as flecainide, antimalarials, chloroquine and quinine, antiepileptics such as carbamazepine, lamotrigine, topiramate, local anesthetics, and muscle relaxants such as cyclobenzaprine. The presentation, good memory is SALT. These often present with shock, altered mental status, and some EKG changes. Cardiac toxicity can include arrhythmias, ventricular tachycardia, and hemodynamic instability, pulmonary edema. There are some EKG changes, as mentioned. They can have CNS toxicity that can progress even to coma. And the management of this is sodium bicarbonate, and that's really what we wanted to talk about today. How does sodium bicarbonate work? In a couple ways. One is it increases sodium. You're giving more sodium to try to overcome that blockade. It also decreases binding and reduces free drug concentration. So general indications for using sodium bicarb is if the QRS is greater than 100, any arrhythmia, severe hypotension, seizure. Experts usually recommend push to decrease the QRS, and then you can continue an infusion. Other literature suggests just push as needed, but the goal is really pH 7.5, 7.55 as a hard stop. And then you also want to stop if the serum sodium gets above 150. You can use hypertonic saline, which helps to increase sodium. Intralipid is an option. Hemodialysis is an option. And then for seizures, of course, benzodiazepine. And some of the antiepileptic medications, including phenytoin, actually are also sodium channel blockers. And so in general, we don't use phenytoin for toxin-induced seizures at all. And then, of course, supportive care would include intubation and mild hyperventilation if needed. I love this example of an abnormal EKG when you can see exactly where and when they push the sodium bicarb. And you can see that widened QRS in a very abnormal pattern that suddenly normalized with one push of sodium bicarbonate. Okay. That's it for the toxidromes. So I was going to move on to some specific ingestions, but I just wanted to pause here and see if there are any questions thus far? You can put them in the chat, or Matea, if you see questions on your webinar panel, I don't know.
No questions at the moment.
No worries, then we'll move on.
Mm.
Okay, so we'll focus on some specific ingestions that are seen more commonly, and then some clinical pearls. So we'll talk about acetaminophen, aspirin, iron, the alcohols, calcium channel and beta blockers, cyanide, and then some oral hypoglycemic agents. I'm assuming some background knowledge, and I recognize that we have an audience who is involved at many different levels of caring for patients with toxins. But we'll assume that all patients here receive attention to ABCs and supportive care, and I won't discuss any doses or specifics like that in just the interest of time. Okay. So we're all familiar with acetaminophen overdose, and this is probably one of the most common overdoses we see. It can be intentional or accidental. So we certainly see teenagers who overdose usually intentionally, and we see young toddlers who have found a bottle and ingest it accidentally. Fortunately, those young patients, it's usually not toxic levels. But how does acetaminophen work, and how does it actually cause toxicity? And as a reminder, it overwhelms normal metabolism pathways. It's increased by the cytochrome P450 system to NAPQI, which is a toxic metabolite, but that is then metabolized by glutathione, and the levels, and that brings that toxic metabolite down. However, we all have a limited amount of glutathione in our body, so when we have an excess of Tylenol, we have excess of that metabolite, and it can cause direct, irreversible hepatic necrosis. We consider a toxic dose about 10 grams in adult. In the child, until recently, we often considered 150 milligrams per kilogram dose a toxic dose. And I've recently learned that now we use more 200 milligrams per kilogram as a toxic dose, which is reassuring. To give you a sense of what we have, so a bottle of children's Tylenol actually contains about 3,200 milligrams. So you can actually see that if a child drank a bottle of children's Tylenol, a 15 kilogram child, that would actually be toxic right there. And it does taste good. So overdose levels peak at 4 hours unless there's other factors. A chronic overdose is a bit more challenging to evaluate and can still have toxicity, but a little bit more difficult. We're familiar with the Rumack-Matthew nomogram to determine the need of starting an antidote. There's higher risk with certain medical conditions and medications because of some baseline decreased glutathione stores, especially in malnutrition. So it's something to keep in mind there. We talk about the 4 stages of toxicity. In the beginning, they have some GI symptoms in the first 24 hours, or maybe asymptomatic. And they develop right upper quadrant abdominal pain, some increased liver function tests and transaminase markers. This can progress to hepatic failure with encephalopathy and coagulopathy and all that goes along with it. And if patient survives, then there can be resolution and recovery, which can take days to weeks. So charcoal, we do recommend decontamination within 1 to 2 hours. But the main treatment here, of course, is NAC, or N-acetylcysteine. This can be given orally, but it's better given IV. It acts in many, many ways, and I've listed a bunch here. I'm not going to read all of that, but one way is as a precursor for glutathione, so to help metabolize NAPQI. We treat if the level at 4 hours is in that potentially toxic range on nomogram. On the nomogram, usually greater than 150. And if we are taking a level after 4 hours, and that can also be plotted on the nomogram based on time of ingestion. If we don't know when it was ingested, then we will usually treat at a lower level to be on the safe side. We'll treat if there's any evidence of hepatic injury, so transaminase is greater than 500, even if it's been more than 24 hours. And then we continue the NAC to complete the protocol. The good thing to know is that if LFTs are normal at 24 hours, the liver is going to be okay. And I also want to highlight some variations in practice. Some places in Canada and actually in North America use a 2-bag protocol, and some use a 3-bag protocol. Same medication, overall total milligrams is not the same, but similar. So in Manitoba, we use a 3-bag protocol. You may receive instruction from poison control for a 2-bag protocol, which is okay. And we'll switch that when the patient arrives and children's emerge and make sure they get the doses. Other variations in practice, some centers continue checking Tylenol, some check just once, some centers stop NAC after the protocol is done, and some others use, will continue NAC and use either Tylenol levels or a normal INR to stop NAC. So there's some variation in practice, which is probably okay, but keep in mind that NAC itself can affect vitamin K clotting factors and can raise the INR. So most toxicology experts recommend rechecking the Tylenol level only in context of a massive overdose. Okay, aspirin. Aspirin is found in many products, or ASA, acetylsalicylic acid. It's found in arthritis cream. It's found in oil of wintergreen. It's found in Pepto-Bismol. And children are rarely on ASA because of concerns about Reye syndrome, but of course it's still available, and many adults take that for preventive reasons as well as treatment reasons. One key point here is that absorption of ASA can be erratic and can be delayed up to 24 hours. So it's important to know symptoms can actually progress, and pediatric patients progress more quickly to severe symptoms. Toxic dose for aspirin is between 10 to 30 grams in an adult and about 150 milligrams per kilogram in a child. I'll mention again oil of wintergreen, which is for some reason a favorite of kids. It does smell like peppermint. Keeping in mind that a bottle of the essential oil of wintergreen is 30 milliliters, and 1 milliliter is equivalent to a 325 milligram aspirin tablet. So if they drink a significant amount, it can be quite dangerous. The presentation of an aspirin overdose is initially gastro, so nausea, vomiting, abdominal pain. It can also have some pylospasm. You have some respiratory symptoms as well, so tachypnea, hyperpnea, and this comes because aspirin directly stimulates the medulla. And ongoing hyperpnea and tachypnea can lead to respiratory alkalosis and pulmonary edema. There are also some direct neurotoxic effects, so headache, tinnitus, hearing loss, delirium, seizures. Directly activates the brain to cause hyperthermia. And then all of the above can lead to dehydration and electrolyte changes, also diaphoresis, emesis, etc. And they have increased lactate from the mitochondrial effects. And having elevated lactate can worsen your tachypnea and respiratory failure. There's a fairly significant mortality rate in aspirin overdoses. We don't see this again as often as Tylenol, perhaps, but it's good to know. So the two take-home messages from this slide are in bold. I won't go over the toxic levels, but good to know. And if you have this, of course, get a level and review it with your toxicologist. The two key points, though, is we mentioned that the GI absorption of aspirin is erratic. And so you really want to take the serial ASA levels, looking at cap gases as well. There may be a pure respiratory alkalosis, but that may progress to a compensated metabolic acidosis. Can have also abnormal blood counts and electrolytes. The second key point is to give dextrose for what we consider neuroglycopenia. So aspirin can actually block glucose utilization in the brain, and so you may actually have neuroglycopenic effects even with normal serum glucose levels. So give dextrose anyways. If there's any any neuro symptoms at all, give dextrose even if your AccuCheck is normal or high. Treatment otherwise is alkalization and IV fluid to enhance elimination, keeping in mind that you want to replace potassium before you give sodium bicarbonate, otherwise it's not going to work. There are some indications for hemodialysis. Some specific ones include levels greater than 900, CNS symptoms, pulmonary edema, renal failure, and if they're not getting better with urinary alkalization. Iron. So readily available to children. It's one of the more common ingestions. They're found in prenatal vitamins, there's iron supplements, some placebo pills of an oral contraceptive pack, and you have to also be cautious of extended release formulations. So iron toxicity is direct cellular toxicity. It's cell necrosis, injury to the mitochondria, uncoupling of oxidative phosphorylation, free radicals, vasodilation, and very dangerous. Toxic dose is about 20 milligrams per kilogram of elemental iron. And those of you who prescribe iron may know the therapeutic dose is 5 to 6 milligrams per kilogram, and the toxic dose is 20. So there's very small therapeutic window here. So again, not to go over the slide in detail, but to talk about the 5 stages of iron toxicity. Initially, so there's GI irritation from the direct injury to the GI mucosa. If you see vomiting in stage 1, that's of course a high concern. Stage 2 is sort of the latent stage for up to 24 hours or so. Don't be falsely reassured. Stage 3, though, is when you really see the evidence of cellular dysfunction. You can have ARDS, your anion gap metabolic acidosis, capillary leak, coagulopathy, renal, neurologic dysfunction, etc. Stage 4, fulminant hepatic failure, and then stage 5 can be scarring and bowel obstruction because of that mucosal injury. Management of an iron overdose. It's worth getting an abdominal x-ray to see if there are any visible tablets. If so, endoscopy or whole bowel irrigation may be indicated. We no longer do gastric lavage. We'll talk more about that later, but we no longer do gastric lavage for poisonings. Volume support for hypovolemic shock, and then for severe symptoms or high levels greater than 90 is deferoxamine, which does a couple of things, including chelating free iron and removing some bound iron. I did put a dose there, but again, not to remember that. Again, in this severe iron overdose, you'll be talking to toxicologists. Usually they give it for 24 hours, then they reassess and then consider repeating. Some citations recommend continuing when the level decreases, but just to know that you can't trust your iron level once you started deferoxamine, just based on how iron levels are checked in the lab. Okay. Doing okay, I hope. Toxicology, it's a huge topic, so a lot to cover in 1 hour. So we'll move on to the alcohols. So ethylene glycol and methanol found in antifreeze and windshield fluid. Toxic dose is very, very, very small. So 0.1 milligram, or sorry, 0.1 milliliters per kilogram. So we recommend assessment even if there's just a small taste of it that's been reported. It can present in different ways, usually GI and neurologic symptoms. There can be ocular symptoms from methanol, elevated vital signs, metabolic acidosis, muscle spasms, heart failure, encephalopathy. 2 things to remember. One is that ethylene glycol can cause renal failure secondary to calcium oxalate crystals. And then methanol, untreated methanol toxicity can lead to blindness from formic acid deposits in the eye. And there's also direct damage to the basal ganglia. Management of alcohol poisoning. The big challenge is actually recognizing it and knowing what to do, but looking for those clues as we've talked about. But once you have that, the management is really fomepizole. So this inhibits alcohol dehydrogenase. It's expensive, but it's life-saving. We used to say if we don't have fomepizole, use alcohol. There used to be IV alcohol, IV ethanol, which we don't use anymore. And the recommendation for using oral ethanol, which could also be effective, would be only if fomepizole is not available if you're very remote. But there are side effects to using that. Options include hemodialysis and then some other rescue agents. Again, all of this would be done in consultation with toxicology. Okay, let's do our 4th poll. A 4-year-old boy presents after eating several of his grandmother's diltiazem tablets. What findings might you expect from a diltiazem ingestion? Hyperglycemia, tachycardia, bronchospasm, hypertension. Let's see the answers. Okay. Yep, so we've got say hyperglycemia, tachycardia, and bronchospasm. Okay. So let's, okay, so the answer is actually hyperglycemia, for those of you who answered that. You actually see bradycardia, not tachycardia, and you don't see bronchospasm in calcium channel blocker overdoses, although you can see it in beta blocker overdoses. And generally you can see hypotension, not hypertension. So a bit of a trick question, but hyperglycemia is the right answer. For the most part, calcium channel and beta blocker overdoses present fairly similarly with decreased cardiac function. Propranolol is especially lipophilic and can cross the blood-brain barrier, decreases heart rate, blood pressure, decreased inotropy, AV block. The main differences between calcium channel and beta blocker overdoses is calcium channel blockers also inhibit insulin release, and so you have hyperglycemia, where beta blockers tend to have hypoglycemia and bronchospasm. Okay. In terms of management, supportive care, but IV fluids, we generally use high-dose insulin and a dextrose protocol now. You can give calcium. Some older treatments which aren't used much anymore include phosphodiesterase inhibitors that theoretically increase contractility and blood pressure, but in reality are not used. Glucagon, again, has some theoretical uses, but not used in real life. Intralipids are an option as well. And there are some other choices. Atropine is often used. The question is whether that makes a huge difference. But a significant overdose, you'll be talking with toxicology. That would be also a theme from this presentation. So a quick slide on calcium channel blockers or the insulin euglycemia therapy. So the calcium channel blockers do at least two significant things. They decrease cardiac inotropy, and they also block calcium influx into the pancreatic islet cells and decrease insulin release. So we've already talked about this causing hyperglycemia, but it also prevents glucose uptake and use by cardiac muscles. So by giving insulin and glucose together at very high dosages, like very high dosages, like 1 to 10 units per kilogram per hour, along with dextrose, it increases cardiac myocyte utilization of glucose, improves clearance of lactate, increases ATPase, increases inotropy, and definitely ongoing supportive care, but it can make quite a difference. Okay. A quick thing on cyanide, and this is my last specific, my second to last specific drug to talk about. The most common exposure is smoke inhalation. So anyone, any patients coming from a setting where there's been a house fire, for example. We know that cyanide interferes with the electron transport chain, can cause cellular hypoxia. They often present hypotensive, low heart rate, can present with GI symptoms, neuro symptoms, renal failure, and rhabdo. We talk about kind of that cherry red skin color, just to know that's usually a post-mortem finding and not so helpful for pre-mortem diagnosis. But usually you know the history and the context and what's going on if a patient's been found next to a fire. Management has also changed over the years. Currently, the recommendation is hydroxycobalamin, which binds to cyanide, so it helps excrete it in the urine. We don't have a level of cyanide per se, so you don't base treatment on a level, but you base it on your elevated lactate. So a lactate up to 7 or 10 is a good indication for using hydroxycobalamin. I'll just mention some old treatments for sodium nitrate and sodium thiosulfate, which are not used anymore. And then potentially hyperbaric oxygen has been used as well. But hydroxycobalamin is your go-to. And finally, I wanted to go over the one pill can kill, and many of us have heard that phrase. This it does apply to sulfonylureas as well as some other medications. So I call these the GLP drugs. So the gliclazide, the glipizide, the glyburide, and I'm a pediatrician, so I actually don't have patients on these medicines. But there are a lot of grandmas and grandpas out there who are on these medicines, and we do see this not infrequently. I will note that not all uh, oral hypoglycemic agents are dangerous. So if you think of metformin, we also see metformin overdoses, but they do not cause hypoglycemia. They cause a lactic acidosis, so operate a little bit differently. But the sulfonylureas can actually be quite severe, especially in a patient who's of kind of a lower weight, so lower weight and a higher milligrams per kilogram. And these present with hypoglycemia and can be very prolonged as well, 24 hours or more. So the management is really dextrose. Monitoring, we often admit these patients overnight and monitor their sugar level, sometimes requiring actually very high supplemental dextrose infusions. We can use octreotide, which helps to inhibit insulin release. Glucagon has been used in the past, but less effective. And then as mentioned, we often monitor for 24 hours. So again, going back to the one pill can kill, somewhat overly dramatic, but if you accept this as hyperbole, it really does take a lower dose to cause adverse effects, especially concerning in children with lower weight. And it contains a number of these things. So calcium channel and beta blockers, benzos, camphor, clonidine, narcotics, and the list goes on. So something to be careful about, and actually from a pediatrician point of view, we emphasize very strongly keeping medications safe, um, both safe from curious toddlers and preschoolers, but also safe ideally from teenagers who are sadly looking for things to take. There's actually a recent initiative that I heard about, and just the beginnings of it. I don't know more details about supplying lock boxes for families who have medications in the home to try to prevent poisonings from all ages of children. Okay, so we'll talk a few slides on management and then we'll open up for questions. So my last poll, 14-year-old girl presents within 1 hour after overdosing on her regular psychiatric medications. Activated charcoal will be ineffective for which of these medications? So activated charcoal will be ineffective for fluoxetine, aripiprazole, quetiapine, or lithium. Okay, so good answer. So overwhelming response for lithium, which is correct. And we'll talk about why that is. So lithium, of course, falls under the category of heavy metals, and we know that charcoal does not work on heavy metals. So for the last few slides, I'd like to focus on management. And this is really quite similar between different toxicity treatments. With some exceptions, and we noted those earlier, but really decontamination if possible to prevent absorption. So giving charcoal within 1 hour for sure, and we often give it within 2 hours in certain situations. We do consider decreased gastromotility, so certain medications such as opioids and anticholinergics can actually decrease GI motility, so you actually may have a bigger, longer window in which to give charcoal. So in general, we say administer within 1 to 2 hours. We do know that charcoal fails, or PHAILS, fails in the setting of pesticides, hydrocarbons, alcohols, acids, alkalis, iron and heavy metals, lithium, and solvents. So just to keep that in mind, can be given PO or NG. Again, the recommendation is to give NG with a secure airway if there's concern for decreased mental status, for which you need airway protection. Whole bowel irrigation is an option. This can be helpful for iron, can be helpful for extended release or enteric-coated tablets, and is generally given with PEG at high volumes per hour, again in consultation with your toxicologist. Potentially endoscopy, pill fragments, if there's an iron in the stomach, sometimes enteric-coated aspirin or Bezor. And just a quick comment on gastric lavage and why that's bad. So it's been a couple of decades since people have commonly used gastric lavage, but many of us did remember hearing about that when we were in our initial training. So why is it bad? Yeah, it's bad if there's any substance that's caustic. It's bad if there's hydrocarbons, foreign bodies, and it's bad if you don't really know what you're doing and you're not using it very frequently. So there was a definitive statement about this from American and European groups of toxicology in the late 90s to say that we're moving away from gastric lavage. And when I spoke to our two main toxicologists here, they last used it in 1989. So it's been a while. And just a note to not talk about it, or, well, you can't talk about it, but definitely don't use it as an option. And it may be found in some old textbooks, but wouldn't use it. And then, we talk about alkalinization. If a weak acid toxin can be helpful, sodium bicarbonate bolus and infusion with that goal pH 7.5, and a goal, of course, narrowing of the QRS. Octreotide, we mentioned in the situation of a sulfonylurea overdose, if there's hypoglycemia with minimal response to D50. Or ongoing high volumes of dextrose. Some indications for dialysis. So stumbled is a good mnemonic. So salicylates. I put theophylline in there because it begins with a T, but Tylenol is better. Theophylline doesn't really exist anymore. But uremia, methanol, barbiturates, phenobarb. We're also moving away from that with anti-seizure treatment, so perhaps fewer overdoses. Lithium, ethylene glycol, and Depakote or valproic acid. So this list of antidotes will wait for the slide handout, but just to know there are some specific ingestions which have specific antidotes. So digoxin, Digifab, a warfarin overdose can be treated with prothrombin concentrates or FFP, neuroleptic malignant syndrome. This slide actually says diphenhydramine and dantrolene, but according to the experts, it's more often used with bromocriptine. Crotalin snake bites and spider bites and scorpions. We don't have a lot of those in Manitoba, but I've seen a fair share of black widow bites where I'm from, but they also have different antivenoms. So, and finally, intralipids. So an IV lipid emulsion can be helpful for some lipophilic medications. This would include like local anesthetic toxicity, tricyclic antidepressants, some antiarrhythmics, et cetera. And again, used with toxicology consultation. For seizures, the mainstay is really benzodiazepines. Other options would include barbiturates, propofol, levetiracetam. Again, avoiding phenytoin. It blocks the sodium channels and really ineffective for toxin-induced seizures. And valproic acid is probably ineffective as well. And then considerations for discharging from your emergency department, if the dose is under the minimum for toxicity, if patients completed the retired time for observation, if you have a safety plan in place, social work may need to be involved, and certainly child and family services becomes involved in certain situations. For our adolescents who present with different toxicities, certainly if it's intentional, there is a plan around mental health, safety, and treatment. Again, and we want to discharge them only if there's no concerns for abuse or suicidal ideation or intent. So that was a whirlwind review of toxicology. I'll stop sharing my slides now, but I'm happy to take questions.